OIS, right? Outpatient interventional suites, as we talked about. So there's a lot of hush hush which is happening about OIS. Are the reimbursements going down? A lot of insurance is catching up on the reimbursements. What is the future for it? Is it bright? No. Is it fading away? Are we at the peak? Are we going down in a couple of? So let me just give you a brief overview. I'll give you very quickly because I think you guys will know about it anyways. So when Obama plan came in, I think that's when most of the reimbursements issues started. They took up the course in 2008. He reduced the premiums by 2,500, so there was a lot of co-payments which were coming on to the physicians. So I think the outpatient labs started getting hit at that point. Actually, might have even increased the cost by about 32% instead of decreasing it. So the outpatient trending started happening about 20 years ago when Medicare approved for outpatient procedures. Everything slowly started coming up with the surgical centers, with the dialysis centers. Then the cardiac cath labs and everything started migrating to the outpatient areas, especially in Texas, California, Florida. But in say big cities like New York, LA, and Chicago, and wherever you want to put outpatient labs, usually that's not the case. Cardiac caths are not approved in New York State as an outpatient, so they have to be done still inpatient in the hospital. So there are about 450 centers currently in the United States as of 2018. So I'm sure by 2000 ending of 2019 they might have become 900 because it has gained a lot of popularity. Dialysis access centers have been there for a long time. I'm talking about centers which perform only peripheral procedures other than dialysis. Um, and a lot of centers have been doing venous interventions off late for a long time. And Dr. Asher can actually attest to that because he's been doing this for a long time. He's one among the pioneers who started outpatient venous interventions. So several drivers for this accelerated growth which happened. Minimally invasive surgical techniques, new forms of anesthesia have come into play. So you can do everything under minimal anesthesia, new techniques of giving anesthesia, ultrasound guided local lidocaine injections as Dr. Asher was showing. Um, most of the insurances are no longer paying for the extended hospital stays, so it's pushing more and more patients towards OBS. Again, most of the patients can go home. It's not only about insurances, but also it's about patient safety and everything. So, and patient comfort, not to downplay it. So in the outpatient-based surgical settings, they have, first of all, the biggest advantage they saw, the insurances and the CMS saw, is decreased amount of cost. It's lower cost, right? It's more convenient and comfort for the patients. So that's what drive everything towards outpatient centers. So over the last 10-year periods, 1995 to 2010, there are a lot of office-based procedures. They are doubled, actually. So when we say doubled, the first question I usually get is, are we doing more amount of unnecessary procedures, right? That's the most common question. As soon as somebody says outpatient lab, the first thing I hear, even though I'm academic with Sinai, I do a lot of academic procedures, even I get to ask that question. People ask me the same question. Oh, do you guys, that means a lot of unnecessary procedures are being done? That's not true though. Increased number of procedures doesn't always mean unnecessary procedures, right? Increased number of procedures could mean that there are decreased number of procedures in the hospitals. So if somebody has done an overlay of this and seen it, I'm pretty sure over the vascular procedures, a lot of cost which was incurred with the vascular procedures must have gone down because of the outpatient centers. That's the way I look at it. I think if you talk, I don't know why this question about outpatient in unnecessary procedures always shows up, because if a physician is going to do unnecessary procedure, he's going to do it in the hospital no matter what. So that doesn't change. Having an outpatient lab doesn't change anything because even everything is monitored. So it doesn't change anything much, right? So the potential benefits are it provides an autonomy. For the physician wise, it provided a lot of autonomy, especially separating yourself away from the hospitals, which a lot of physicians feel it. That gave an autonomy and in hospital. As Dr. Asher was saying, I think all the physicians who came in here, Dr. Ballard, Dr. Asher mentioned it, autonomy is very important. And also, you're multitasking. So you are actually producing a lot more out of your time than just doing one procedure in 3 hours, right? You're doing the procedure in the downtime in the hospitals. Usually you have to just sitting there waiting for the patients to come into the room. So you have a 1.5 hour of downtime. That's a waste of physician time. In that 1.5 hours, you can run your office, you can do venous procedures, you can do a lot of stuff, you're multitasking. That's more effective way of putting it for the physician itself. So outlooks on the outpatient services, right? Outpatient centers are all over, growing all over the world. It's not just America, it's in all over the world, especially in Southeast Asia. Actually, outpatient centers are gaining a lot of popularity in India, China, Japan, Singapore, big time. Um, so there's a lot of the annual revenue which comes in general from the surgical centers to any other industry and everything is about $8 billion. This is of 2017. It's a large number which comes out of it, but I think overall, if you look at the hospital costs, I think we have cut back on the costs. The future, the outpatient, the effect on the future, how does it come? My take on it is it's going to reduce the amount of costs. The more number of outpatient procedures, the less number of expenditure is going to be for the Medicare CMS. That's how I think CMS should look at it. And it's safer for the patients. It's much easier for the patients. With the amount of advancements we have in all the peripheral artery interventions, most of the procedures can be done as an outpatient. Again, why outpatient, why office-based, right? Once you look at the congressional budget review, if you look at it, a lot of money actually not goes into the procedure itself. It goes into the costs other than the procedure. Hospital stays, hospital staff, overnight stays, which is going to take a lot of cost cut. So convenient for the patient and the physician, less costly for the patient for sure, if you take a look at it. Even if there is a significant copay, there's a huge deal, a less amount of copay for the patients. It's for the insurance companies, it's a big yes. I think it's a big plus point for them if they look at it that way. It's more efficient, definitely safe. I think there's a large amount of studies which were done. So the biggest problem, then you can say if everything is bright, what is so problem with outpatient-based surgeries, right? Because the vascular reimbursements are going down. We are down by about 30% in the past 3 years. I think this year is the only year when the rates have stabilized and they have been doing. I think it's going to put a negative impact because if it's not going to be beneficial for an outpatient setting, a lot of practices might just drop using it, right? Patient benefits, big time. I personally am a huge fan of outpatient labs because it creates a big sense of comfort zone between the physicians and the patients. Because patients get to see the physicians more and more in the outpatient lab because it's a very small setting. We keep on walking across our office and it creates a kind of a bond between the patients. Patients have more trust over the physician. It creates much more familiar environment because they come to the office all the time, so they see the staff. So for them to come and get a procedure done, there's a less amount of anxiety involved. So no travel time to the hospital, that's the biggest physician benefit. Again, reimbursements are good, so there's a big profit margin, more control over the environment because it's your office. And you can do whenever you want and you can stop whenever you want. Do it at your own schedule, right? Again, it's a higher global fees, so that's the biggest advantage for the physician. There is a global fees. So even if you have a significant amount of cost based on the global fees, you can get away with it. Again, cuts are always talking about. Now MACRA has come into play. Most of the procedures can be done, right? What happens based on the way insurance companies and CMS are looking at it, I think OBS might come to a plateau stage or even might go in decline. So we always see the patients through our insurance company's eyes, right? Whatever the insurance company says, feels is what we feel. Unfortunate, but that's the truth right now. This is so safety data, right? I think Dr. Abu Faris has already gone over this paper, which is the most popular paper in the outpatient setting, where they looked at about 1,500 patients and they saw significant safety margin on it. A lot of studies have been done based on this. I don't want to go over everything again. A lot of number of procedures are being done, and the safety margin is huge. They actually saw a significant amount of increased safety margin when compared to the hospital procedures in the same amount of setting. So again, increasing popularity, of course, it's more in the Northeast. We are more popular. South, greatly popular. The reason being, Texas, you can do outpatient cardiac procedures, and of course in California, you can see wherever you can do more number of cardiac procedures, you have more number of labs coming into play. So again, success rate is very high with it. Again, if every lab is accredited and nicely recognized, I think the safety margin is great. That's the future. So without any delay, we'll go to the next talk, case presentation by Dr. Tijani.